So hi, my name's Dr. Toni Storm Dickerson. I'm a breast surgeon with Compass Oncology, and I'm very excited to have an opportunity to talk with everyone about breast imaging. It's a very complicated issue, and there's a lot of confusion out there, and hopefully we can kind of help simplify things with some real-life context and a whole lot of data. So we know that breast cancer is common, and that it affects about 1 in 8 women. And we know that it is cancer is common. But if you think about all cancers, for women, breast cancer makes up about half of those cancers. Even more, if you think about in the United States alone, as of January 2018, we have 3.4 million women currently either undergoing treatment for breast cancer or living with that diagnosis. So this is a common disease, and it affects a lot of people. What can we do about this? We know that breast cancer is the second biggest killer of women over the age of 50 and the first biggest cancer killer under that age. We also know that our survival overall at 5 years is pretty dang good, okay, about 89.7%, so almost 90%. So what else can we do to make this even better? Well, one thing that we've seen when we look at trends, and this is through data that the US government puts out as they track all of our patients, is that we know that overall the breast cancer rate of death has decreased dramatically by about 40%. I think the exact number is 37.4%. So very dramatically up until 2015. So that's great, we're doing well. But if you actually look carefully, we don't see that same decrease in women under the age of 50. So that's in older women, women over the age of 50. So when we think about breast cancer in younger women, we need to think about the fact that they tend to develop more aggressive malignancies, that they tend to be more likely to need additional therapies like chemotherapy, that they're at a very productive time in their life, that they have young children, and so how does that impact them? And how do we watch out for them? And what about trying to do screening based on women's risk? We also know that the vast majority of breast cancers are spontaneous, and that we cannot simply use genetics or a family history as an indicator for your risk, because the vast majority of women, at least 85%, are going to develop breast cancer spontaneously. They may have no family history. So if we kind of look at the data over time, we know that when we look at when we initiated breast imaging, and that's the big red line, that we saw a big increase in the number of women diagnosed with breast cancer. But initially, we didn't see a huge drop in their deaths. But we do with this latest data that came out through SEER, again, the government, as of 2014, we see a huge drop. And this is very significant, and that's because breast cancer is not a fast killer, usually. We're very good at treating this disease, and women can live for several years before they're going to die from it. So in order to say, is an intervention making a difference, we have to look over a certain period of time. And so we see a rather dramatic drop in the breast cancer deaths, but you have to wait a few years to be able to see that. So also in context, we need to remember that while breast cancer is often kind of presented as a disease of the elderly, it's really not so much. The age group that's most commonly diagnosed with breast cancer in this country is the age group between 55 and 64. So here's a graph that is often used to discuss and describe the incidence of breast cancer, and it's not wrong. But I think contextually it's a little bit misleading because it shows this large jump as we age. Well, that's true, there is a jump as we age. But remember, most of the women alive are in this range, okay? So if that's the average age that's being diagnosed, if we break it down into context in terms of number of breast cancers diagnosed per year in the United States, this is what we see. So we see again at this 55 to 64 year age is our #1 group. But we see almost an equal distribution at 10 years younger, 45 to 54, as we do older. And look here, folks, we still see breast cancer in young women. I have several young women in my practice. If you look here, the number of women who are in that 35 to 44 age group is definitely larger than the older ones. Of course, as you're getting older, you're less likely to be alive as the years progress. But so when we put it into context, it's really more like this. And I think that's very important because who are we trying to diagnose breast cancer in so that we can find it, so that we can beat it, and so that we can hopefully also not only help them to survive, but help them to live better with possibly less treatment, right? And we know that survival is better when breast cancer is diagnosed earlier. And that's just a quick slide showing that. When we have breast cancers diagnosed at an earlier stage, the survival is better. So in my practice, I've pulled my numbers, and over 50% of my patients are under the age of 55, which actually makes sense. When I first saw this number, I was a little bit surprised. But I think, again, that goes to this thought that we think of breast cancer as being a disease of the elderly, and that's not completely untrue. But it is certainly not the whole story. It's also a disease of women of much younger ages. This is just a quick slide that shows Oregon and Washington, and it talks about incidence. So the darker red, the more common breast cancer is. And you can see that we have a high incidence. On this slide, it shows how many people are dying from the breast cancer. So Washington's doing a better job of fighting the disease than is Oregon. And we can talk about what that is on another TED Talk. So where does the U.S. Preventive Services Task Force fit into all of this? And what are those recommendations? And how do we kind of make sense of it? So when they came out with their recommendations, which was an update in 2009 to say that we should do breast mammograms every other year starting at age 50, they had done that after doing an in-depth look at who's going to benefit, who's going to have the biggest bang for their buck from mammograms at what age. And a big part of this is they also said, who's more likely to have the negative or downside effects of imaging and biopsies? And what is that toll? So what is the harm? So when they looked at their data, which is what we would say in general is kind of conservative, in other words, they showed lower survival rates with imaging than some other groups, but they still saw a 15% benefit in imaging starting at age 40. They also saw an increased number in additional biopsies and what we would call a false positive. So a biopsy that wasn't malignant. So what they tried to say was, and I put it in red for you here, that their primary concern with the mammogram was not just its ability to detect cancer, but again, harm of imaging, outweighing the benefit based on unnecessary imaging and biopsies, as well as cost. That was definitely part of it. It's also important to keep in mind that when they did their evaluation of the data, they used 2D imaging, okay, and film mammography. They did not use 3D breast imaging. 3D breast imaging is a pretty incredibly excellent way to do imaging. So we've had several modeling studies that have been done to try to understand when we see this benefit that we have noticed in the drop in mortality with breast cancer in that Sears data since 2014. Is that because of imaging? Is that because of chemotherapy? Is it because of both? And most of our data would suggest it's actually because of both. So chemotherapy certainly has improved. And what we have here is the Cancer Intervention and Surveillance Network, their models. Now these same models were used by both the American Cancer Society and the U.S. Preventive Services Task Force to make their recommendations. So this is well established. And what they found is when they looked at data from 2000, they saw that there was a 37% drop in mortality of breast cancer, and that was based about 44% on screening and about 56% on treatment. Okay, so chemo and endocrine therapy, surgery, that kind of intervention. In 2012, they estimated that the decrease was 49%, so survival had definitely improved from 37 to 49%. Now, imaging was a little bit less at 37%, and treatment was up to 63%. So when we think about what was part of this kind of reevaluation and all of this debate, and I'm sure everybody's been reading about the New York Times and everything else about, do mammograms work? Are we causing women additional procedures that they don't need? False positives, etc. Well, because of all of this debate and the debate about, well, wait a second, mammograms save lives and we need to do imaging, both the U.S. Preventive Services Task Force and the ASC and several other bodies actually re-looked at the data. And they re-presented their recommendations as of 2015. And in 2015, what the U.S. Preventive Services Task Force basically said is, well, we should be a little more chill, a little more relaxed, and bring in the patients and how they feel about things, which I think is a little vague and confusing at times, but they still recommended that they continue with the recommendation for imaging to start, mammograms to start annually at age 50, and then to go every other year. And again, they felt that one of their biggest concerns was the idea of false positives. So I want to talk about those false positives a little bit. So the U.S. Preventive Services Task Force did not define what they felt was acceptable in context of lives lost with their false positives. So if we look again at what came out from, again, the body that they used to do their profiling, the National Cancer Institute's Cancer Intervention and Surveillance Modeling Network, we see that they predicted that mammograms starting annually at age 40 would result in 100,000 lives saved. And that mammograms starting at age 45 and then going every other year till age 55 would result in 38,000 lives lost over doing annual at age 40. So we have to think about all of this context. And we have to look at what other data do we have. We have a lot of hard data. Harvard came out with a great study, and what they showed was that in their two largest hospitals, 70% of the women who died, not diagnosed with, died from breast cancer, did not perform regular screening mammography. So how does all of this fit into where we're at and how we look at moving forward? And mortality, and diagnosis and tumor size. Well, we have to, again, put it into context. We have to remember also that we now have 3D mammography. 3D mammography is extremely powerful in the fact that, one, it has been found in Washington state legislature to be something that insurance needs to support and pay for because it is no longer experimental. And what 3D mammography does is it decreases the false positive rate by 17.5% and increases the diagnostic rate by 33.9%. So these are really powerful numbers. And again, remember that the U.S. Preventive Services Task Force, when they made their recommendations, did not use 3D mammography. 3D mammography is better at looking at denser breasts, younger women's breasts. And so part of their concern was overdiagnosis because patients were having additional biopsies that they didn't need to have, that the imaging wasn't as good. Well, 3D mammography has pretty much thrown most of that away. That doesn't mean no one ever has an imaging study that they don't need to. In fact, there's a national study that shows that of women who have mammograms, about 20% are called back for additional imaging. Of that 20%, half, fully half, have additional imaging and are told everything is fine. Of that other half, so now we're down to 10%, of them, half of those, so now we're down to 5%, are told that they should come back in 6 months. Of that remaining 5% that have a biopsy, 40% of those are malignant. So these are not a lot of additional unnecessary biopsies. We're talking about around 3%. So I want to put this into context for everybody. And as a surgeon, I have the extreme privilege of taking care of patients and of knowing these people as a lot more than numbers. And so I want to share with you a little bit of what we do and some cases to put it into context. So first I want to show you a case of an 83-year-old woman. And the question is, she's severely demented. Would you do mammography? Most people are going to say absolutely not. She's severely demented, she's 83, are you going to make an intervention? And that's actually a very reasonable call. But what would you do when she's 73, 10 years younger, and very mildly demented and otherwise healthy? Would you do imaging? The U.S. Preventive Services Task Force, based on their recommendations, said that in the women over 70, they actually didn't look at data, so they didn't really have a recommendation. I'm not sure how that's become an anti-recommendation, but in fact, they had no particular recommendation for this age group. But unfortunately, because we have many of these people in positions of policy making, it is something that insurance companies grab onto. So we as providers need to look out for our patients. This is our job, okay? So an 83-year-old, when she's 73 and mildly demented, is somebody that maybe we should think about a mammogram on. If we look at actuary tables or tables that tell us how long is somebody expected to live, well, if you're already 73, you're likely going to live, if you're a woman, another 12.9 years, so she's going to be alive. So here's what she came into my office with. And I know this is hard for you guys to see because you're not used to looking at stuff, but this is her chest wall. This is the inferior kind of outside part of her breast, and that is a tumor that's fungating and ulcerating through the skin and stuck into her bone. And there's no reason for that because a little teeny tiny whittle, and remember that's what I do, could have taken care of this 10 years before. And this was a very favorable, very slow growing cancer that is now very far advanced and become identified because it's symptomatic, because it's hurting her. So what about a healthy 32-year-old woman? She has no family history. Would you do a breast exam? I bring that up because the U.S. Preventive Services Task Force said that a clinical breast exam is what they call unclear if there's benefit. They're not sure if there's harm or benefit, so it kind of sits in this interim category. And self-breast exam is considered to be harmful. So, 32 years old. So what you see here is a young woman who had a palpable mass that she noticed. And it's quite high in her breast, but it's even visible. And you can see the arrow, and there's a small area of bruising. And as she raises her arms up, you can actually see the tumor kind of bounce over her ribs. So I personally think that clinical breast exam is actually very important, and I think that self-breast exam is important as well. So what about a healthy 42-year-old woman, no complaints, normal exam, and no family history? The U.S. Preventive Services Task Force would say she should not have imaging. And I would say we're not going to be able to use family history as a safe way to say if she has risk, because again, remember, the vast majority of breast cancers are spontaneous. So what she ended up with was a 6.4 centimeter precancer. That's very, very large in a relatively small-breasted woman. So that's very significant when we have a cancer that we can diagnose when it's still contained within the ducts of the breast and have 100% cure. Case 4. What about a 38-year-old complaining of breast changes? Would you do an exam? Would you do imaging? So I saw this woman, and if you look, you can see, here's her arms up, there's her arms down. You can see this large bulge and the defect. Hopefully that's showing up. And the point that's really important about her is she went to her providers and said, I think something's going on. And they said, no, we don't think there's anything. Until she continued to say something as it became larger and larger and more deforming to her and more concerning. And here's what she had. Breast cancer, now stage 2, with spread to her lymph nodes. If you remember, we talked earlier, when the cancer goes into the lymph nodes, the stage advances and your potential need for, 1, more treatment, such as chemotherapy, and your potential for a more advanced disease that is more life-threatening go up dramatically. Case number 5, a 42-year-old, family history not well known. Exam, would you do an exam? Would you image her? Again, the recommendation is she shouldn't do self-breast exams. Maybe you should examine her, maybe you shouldn't, and you shouldn't do breast imaging. So you do an exam and it's benign. Genetics are negative, and what she ends up with is a 1.7 centimeter malignancy that's node negative and is found because you did breast imaging and allows her to avoid a mastectomy, to avoid chemotherapy. Now, 26-year-old comes in to see you. Do you do an exam? The U.S. Preventive Services Task Force would say absolutely not. Do you do imaging? The answer is no. And in most 26-year-olds, you wouldn't. But I think you would look at her. I would recommend that you look at her if you're a provider. And I'd recommend that you look at yourself if you're a woman or a man with a strong family history as well. So now she's 27 years old, and she says, my breast doesn't look right. Do you do an exam? What do you do? Well, this young woman happened to have gone into her primary care when she first noticed a little something and had no exam and thought, it's probably nothing. Then when she was 27, she went into Planned Parenthood and said, my breast is really getting weird. It hurts, it's bigger, something is up. They ordered an ultrasound. I've seen this ultrasound, and what's a little bit alarming about it is that every bit of the imaged field was disease. And because it was all disease, it was misread as dense breasts and benign rather than as malignant. So because they said that it was a benign ultrasound, she was sent away. She then showed up 6 months later to a OBGYN because she's having significant pain. And the OBGYN calls me and says, I'm really worried. I know she had benign imaging, but I think something's up. And thank goodness she did. She did a great job. That's a good provider. Another picture of that breast. Here's what she had at 27 years old. Stage 4 disease. That means she had disease that had already gone to other organs. Not just lymph node, but bone and lung. This is now disease that we cannot cure in a 27-year-old who'd been complaining of her breasts for a year and a half. That may have been absolutely curable. And now, while we will slow this disease and we will help her because we really do have great treatment and we've improved, we're likely to not be able to stop this disease, and she will very likely die from it. And then the last thing I want to leave you guys with is that these are not rare exceptions. This is an example from my own practice of patients that I saw last fall in a 2-month period. So I would really encourage everyone to please do your self-breast exams. Don't be afraid, just check yourself. Nobody's going to know you like you are going to know you. Do your mammograms starting at age 40. Do them every year. If you can, do them 3D. When you get to the older ages, like over 70, that's when you can start talking about every other year, and it should be based on your overall health. If you're very unhealthy, then no, you don't need to be doing mammograms. But if you're expecting to be alive in 5 years, you should do your mammogram. For more information, please visit us at Compass Oncology. We are here for you. We really, truly love what we do, and we are honored to take care of you. Thank you so much.